So my name's Jenna. I'm one of the fifth years. Today we're going to go through pharmacy for finals. Now it's quite a big topic, so we're going to start and just do part one today, and then do part two on Tuesday of next week. So starting off, just using the chat function, can you tell me what are the essential requirements for a prescription? Great. Anything else? Yeah. Okay. As you're all warming up. So firstly, we start with patient identifiers, as some of you said. So you need to make sure you've got a full name and the address and the age or date of birth. It's actually only a legal requirement to put the age on if a patient is under 12 years old, but it's good practice to just put that on for everybody to make sure you've definitely got it. Next, it's the drug details. So you need to put the name of the drug. In some cases, you can use the brand name. In others, you need to go for a more generic. So you might use the brand name for things like insulin or lithium, where you might say things like Act Rapid rather than just putting insulin. We'll come on to specific occasions where you need to do that in more detail. Next is the formulation. So that's whether, is it a tablet, is it a capsule, is it a solution? It's important that you put that onto different medications just so the nurses know exactly what you mean. And then with those medications that are solutions, you need to put the strength on, so to ensure that you're not dosing it inappropriately. Next, you put in your dose. As we all know, that you need to put in milligrams, grams or micrograms, and you should make sure that you write those out properly rather than just putting mcg because it can be misinterpreted. And the quantity, so this is BD, OD, TDS, and the start date as well. Next, you need to make sure that you sign it and you date it. It's really important that you do that. If you don't, then it's not prescribed. And most importantly, as Beth said, you need to put the allergies on. So the 5 main things that you could be tested on are opioids, renal impairment, fluids, anticoagulation, and insulin. For today, we're just going to look at opioids, renal impairment, and fluids, just so that it's not too big of a teaching at the moment. So starting with opioids, it's important that you know some things about them. So you need to recognise which is an immediate release and which is a modified release opioid. It's easiest if you just pick 2 that you use all the time. So I used to always just pick Oromorph and Zomorph and just keep those 2 as the ones that I knew. If you start like mix and matching, it just means that you've just got more and more to remember. We all know that we're trying to limit the amount that we're having to try to remember at the moment. Also, just recognise which is the most potent and which is the least potent of these. Now, this information can all be found on the BNF, and we'll come on to where exactly you find that. So starting off with a case. So you've got Mr. Jones. He's a 68-year-old male and he's recovering on the surgical ward post-elective appendectomy 2 days ago. He's complaining of abdominal pain and is currently prescribed paracetamol 1 gram TDS, QDS or other PRN. So we want you to prescribe some regular opioids for this patient. Earlier on the Facebook page, I put the university prescription charts on there. If you manage to print those off, then give it a go prescribing. If not, don't worry too much, just use them as a basic guide, or just give it a go on some paper and we'll go over it. So I'll just give you a couple of minutes to try that out. If you let me know on the chat when you're done. Has everyone managed to give it a go? Great, thanks, Danny. So the important thing to consider when you are prescribing opioids is that you think about the severity and the type of pain. If the patient isn't in a lot of pain, then you're not going to go straight for a morphine. You need to use the WHO pain ladder, which I'm sure you've all heard of, and start with paracetamol or ibuprofen and then step up to opioids. Also think about whether this is acute or chronic pain, whether the patient is opioid naive or not, and their renal function. So does anyone know which opioids are recommended for use if someone has impaired renal function? Yeah, yeah, brilliant. Okay, brilliant. So you're absolutely right. Fentanyl and alfentanil are and oxycodone are all safe to use, and so is buprenorphine. So that's another one of the patches. The ones that you need to avoid are codeine, dihydrocodone, tramadol, morphine, and diamorphine. So because opioids are renally excreted, they can accumulate and cause toxicity and renal impairment. So it's really important that you know their renal function before you're prescribing. Kate, absolutely right that this is probably fentanyl's a bit strong for this case, but we don't know about this guy's renal function. We're just kind of assuming that it's okay at the moment. So secondly, we want to think about, is he opioid naive or a regular opioid user? Again, we don't actually know, so it's safer just to assume that he's opioid naive. It's always best to start on a lower kind of morphine and titrate someone up than to just go full whack and give them loads, because you're just going to cause toxicity if they've never actually had opioids before. So for an opioid naive patient, you'd start with a 10 milligram modified release morphine twice a day, or an intermediate release for 5 milligrams UDS. And for a regular opioid user, you'd use 20 milligrams of modified release or a 10 milligram immediate release. So therefore, back to our case, we do something like Zomorph, which is modified release. We'd use 10 milligrams, and that's twice a day. So as you can see, it's really important that you put the medication, you put the dose, the route, the indication for this, and then sign and date it. Also important that you put some contact details on there. Obviously, we don't have beat numbers. In an OSCE scenario, you'd probably be provided with one, or if not, just put 1, 2, 3, 4. You don't need to write BD, OD, etc. into the dose box. This is indicated by the times that you put on there, so you can kind of just do one or the other. It's best if you do put the times on, because then you can space the intervals. If you don't put them, it's potentially at risk that someone could fill it in for you and therefore not put the right intervals in between. So case 2, Mrs. Smith is an 85-year-old female. She's been admitted to the ward on codeine, 60 milligrams QDS for chronic pain. Her pain is worsening and the decision is made to change to a morphine preparation. Prescribe oral morphine for this patient. So again, I'll give you a couple of minutes to give that a go, and someone let me know when you're ready. Right, so let's carry on in the interest of time. So the way this is a regular question that comes up. So it's all about converting opioids it's really easy for them to put in, and it's actually easy to do, so just as long as you know how to do it. So you start with your morphine preparation, and you need to work out what the total dose is in 24 hours. You're then going to divide or multiply this by the relative potency of what you're changing the medication to, and this will give you the new dose in 24 hours, which you then divide into the dose intervals. All of this information is in the BNF. So where you find that, you can see my screen, is on the BNF homepage. You go to Medicines Guidance, which is down here, and then you go on Prescribing in Palliative Care. Scroll down. And on here, you've got this table here, which shows you all of the equivalent doses. So this is all equivalent to morphine 10 milligrams, and you can work out exactly what needs to be changed. So back to our case. So we know that she's on codeine 60 milligrams QDS, so that's 240 milligrams in 24 hours. The relative potency of morphine to codeine is 1 milligram to 10 milligrams. So we're going to divide that dose by 10. That gives us 24 milligrams in 24 hours of morphine. That means that we're going to split it into twice a day. So morphine 12 milligrams BD. Does that make sense? So then if you're writing this up, you'd write it up just as we did in the last one, picking a modified release and 12 milligrams. In reality, you'd probably go for 10, 15, 20, just in case of the ease of tablets. I'm not sure you can get a 1 milligram tablet, but in the interest of this case, we'll pretend that we can. So case 3, Mr. Blake is a 75-year-old male and he's prescribed Zomorph 30 milligrams BD. He's experiencing further pain and you're asked to prescribe breakthrough analgesia for this patient. Oh wait, I've got a question. So it doesn't have to be BD, no, it depends what you're picking. So if you're picking, this for the last case, so because I picked Zomorph, which is a modified release, that's BD. If you picked something that was immediate release, such as Oromorph, then that would be QDS. So it's more what you're picking. In the case of someone that's got chronic pain, you'd probably want to give something that's modified release because it's giving them more pain relief throughout the day. And then you do what we're coming on to for the next bit as well. Okay, so everyone want to have a go with this one and work out what breakthrough analgesia will be. Yeah, great. So the way that we work out breakthrough analgesia is we have to calculate a sixth and a tenth of the daily opioid dose. So the way we do that again is work out how much they're receiving in 24 hours, like you said, 60 milligrams, and then we divide this by both 6 and 10. The best thing to do with breakthrough analgesia is provide a range. This is something that's prescribed PRN, so that's as necessary. So if you give a range, then it means that if they're just in a little bit of pain, then you can just give 5 milligrams. If they're in a lot of pain, then you can give a bit more. So coming back to our case then, as you said, he's got 60 milligrams in 24 hours. So dividing that by 6 and 10 gives us a range of 6 to 10 milligrams and made the maths nice and easy for everybody. We're giving an immediate release morphine. This is something that you'd prescribe for when the patient is getting active pain, when they're waiting for their regular pain relief to be given. So you want something that's going to work straight away. So you want an immediate release. As I said, I'd normally pick Oromorph. This is a solution that comes in 10 milligram per 5 mil. So in sense of that, then you can't really give 6 milligrams very easily. So it's easier to just give it in 5 to 10 milligram intervals. And the frequency of that is 4 to 6 hours as necessary. So writing that up is in the PRN side of the drug chart, or the as required. So you need to make sure, as I said, that it's a solution. So you need to give the strength. You need to always give the indication for any PRN medication. Make sure you give the frequency and the maximum dose that they could have in 24 hours. This is just to stop it being given any more than it can be in a day. You don't want to give anyone any toxicity by giving them more than they can actually handle in a day. Okay, any questions? Okay, so something else that you might get asked about is opioid toxicity. So what signs or symptoms would you expect? Yeah. Brilliant. So absolutely get pinpoint pupils, respiratory depression, hallucinations, agitation, sedation, nausea and vomiting, and CNS excitation. So does anyone know how you treat this? Yeah, brilliant. So you give naloxone. So this is something that is so easy for them to ask you either in the papers or in an OSCE. You all know what it is. So naloxone is the antidote for opioids. You give 400 micrograms initially and then can give it at 1 minute intervals. All of the dosing is in the BNF. You wouldn't be expected to know the dosing regime off the top of your head. And it's not really safe to kind of rely on that anyway. Even in hospital, they'd always check the dose just to be doubly sure, especially if they start giving it at more intervals as necessary. So, any questions about opioids before we move on? Just a quick overview of everything that they could ask you. No? Right, okay, so moving on to renal impairment. So, a lot of drugs are excreted by the kidney, and in renal impairment, as we already said, that this can lead to drugs accumulating and causing toxicity. Now, drugs that are more likely to do this have narrow therapeutic windows, high protein binding capacity, active metabolites, and a high water solubility. So does anyone know how you would assess renal function? Yeah, great, okay. So you can use the EGFR. However, that can't be used for children, elderly patients, people with extreme body weight, so anorexia or obese, metabolic states, or pregnancy. Therefore, it can't be used for quite a lot of patients. So is there something that you can use instead, which is perhaps more accurate? Okay, you're close with ACR, so it's actually the creatinine clearance, and you work this out using the Cockcroft and Galt formula. This could be something that you're asked to work out. This little formula can be found in BNF, so you do not need to remember it. They'd only ever ask you to do this with the formula there. They'd never expect you to remember this. In reality, this is always worked out for you by the pharmacist. So you don't really need to know exactly the formula, and also it's so readily available on different apps like the BNF app and the MedCalc app, so you don't need to remember it. But exam-wise, again, go to the BNF, go to medicines guidance and prescribing in renal impairment. And then if we scroll down, so this is telling you all about CKD, and then you go down to here to the Cockcroft and Galt, and this is the formula. So it tells you everything about what you need to know and the constants. Okay. So a 76-year-old patient on the respiratory ward is found to have a reduced urine output and a creatinine of 2.3. Which of these patients' medications are likely to have caused this? Anything else? There may be more than one. Yeah. Any others? Okay, So the ones that could cause this are ramipril, furosemide, and ibuprofen. Metformin would not cause this usually. So basically what's happening here, what's happened to this patient? Yeah, so he's got an AKI. Now, an easy way to remember the drugs that cause AKI is mnemonic Canada. So it's contrast media, aminoglycosides or glycopeptides, NSAIDs, ACE inhibitors, diuretics, and angiotensin II receptor blockers. This is, again, something that they love to ask about. It's so easy for them to test. So just remember this little mnemonic if that's the way you work. I love mnemonic, which you may start to tell by the end of this. And honestly, it is so helpful. So similarly, you're then asked to review this patient's medication in light of his AKI. So his creatinine clearance has been worked out to be 26. So Danny, this is what this next question will be coming on to. So have a look at each one of these medications and tell me what you'd like to do to each of them. Yeah. Great. So again, another mnemonic for you. So the medications that you need to review in AKI. So you can remember this by Damon Sang. It's very strange. I didn't make this one up. And it's one of those ones that's so ridiculous that I think you remember it, hopefully. So it stands for diuretics. With these, you need to withhold them for 24 to 48 hours and then review the patient and see how they're doing. Same with aldosterone antagonists. Metformin is contraindicated if the EGFR is less than 30. In any other case, it's fine to use, but you need to use it with caution. Opioids, as we said before, we need to switch those to one of the ones that's safe to use, such as oxycodone, fentanyl, alfentanil. NSAIDs, avoid or use them for as short time as possible. Sulfonylureas, again, you need to avoid them. ACE inhibitors and ARBs, avoid or use for a short term. Does anyone know a condition in which if you give an ACE inhibitor, it might completely drop off the renal function? Yeah, absolutely, yes. So if someone has bilateral renal artery stenosis and you give them an ACE inhibitor, then all that's going to do is constrict the already constricted renal arteries and mean that there is nothing going through your kidneys. So when you give an ACE inhibitor, it's really important that after 7 days you test their renal function. And that's pretty much the only way that renal artery stenosis is ever diagnosed, by people having an ACE inhibitor and their kidney function throwing off. In that instance, you need to stop the use of ACE inhibitors and not use them again. Same with AR2Bs, because they do exactly the same thing. NOACs. So with these, you need to make sure that you reduce the dose if the creatinine clearance is less than 30, and they're completely contraindicated if the creatinine clearance is less than 15. Gabapentin and pregabalin, again, just make sure that you reduce the dose and keep an eye on those. So going back to our case, again, these can all be found on the BNF. So you don't need to remember any of this. If you go to each of the drugs, like if say you're giving one of these cases, go to each one of the drugs and click on renal impairment and it'll tell you exactly what you need to do. I'd say in an OSCE, even when you're sure, when you see that they're on ramipril and their renal function is completely gone and you know you need to stop it, I'd always just check, just for your own peace of mind that you know you've definitely done it. Okay, so looking at this, then for his ramipril, he's only on 2.5 milligrams a day. And the BNF actually says that he can have a max dose of 5 milligrams with his renal function. So we can keep that, but again, we'd want to just keep an eye on it. The furosemide, 20 milligrams, would just withhold that for 24 hours and keep an eye. Salbutamol is absolutely fine. The apixaban, we need to reduce his dose. Ibuprofen, we need to withhold. Atorvastatin is fine, and the metformin, we need to reduce his dose. And that's because his creatinine clearance is so low. Okay, so with the same patient, you notice that his daily bloods on that his potassium is 6.5, and therefore you order an ECG. What signs can be seen on the ECG in hyperkalemia? Yeah, brilliant. Anything other than the T waves? Yeah, nice. Yeah, okay, brilliant. So yeah, the main thing is the tall tented T waves. And the potassium needs to be really, really high to get these tall tented T waves, and it's what we all remember. But in reality, you may not actually see those. So it's a good little buzzword for any exam question, but just bear in mind that there are other factors to the ECG as well, such as having a prolonged PR, flat or absent P waves, SD depression, or a widened QRS. Okay, so the management of hyperkalemia. So if your potassium is over 7 or it's 6 to 7 with ECG changes, then you need to give calcium gluconate. So this is 10 mils of 10% over 10 minutes. And you can remember this as 10, 10, 10. Now this acts to stabilize the myocardium. So all that's doing is protecting the heart. It's not actually doing anything about the high level of potassium that you've got. So then you want to move on to kind of trying to shift the potassium. So to do this, you need to give 10 units of soluble insulin, and this is either Act Rapid or Humulin S. Now that will depend on where you work, basically, as to which one they try to use. And this is in 250 mils of glucose, and this is over 120 minutes. You can also give nebulized salbutamol, 5 milligrams PRN, and these will both be shifting the potassium from the extracellular into the intracellular compartment. Other therapies that you can give are calcium resonium. Now, this actually isn't really used in practice because it's so slow acting, and it also is very constipating. So if you were going to give it, you'd want to co-prescribe lactulose just to completely get rid of that side effect. But as I said, it's often not used. Another one you can do is an IV furosemide bolus, but you need to make sure that the blood pressure is okay and that they're not overloaded. Sorry, that they are overloaded. Another one you can consider is dialysis. And a way to remember the indications for dialysis is AEIOU. So if they have an acidemia, if they have any electrolyte abnormalities, if they're intoxicated, overloaded, or they're uremic. Okay, again, you do not need to remember this. This can all be found in the fluids and electrolytes part of the treatment summaries. So to find those, again, go to the BNF, and we go to treatment summaries, and we go down to fluids and electrolytes, and on here, oral potassium and managing hyperkalemia. So it will give you every single step in this section. Okay. Again, this is something that's so easy for them to ask. So just have a slight understanding of the steps. I'd say remember that it's calcium gluconate that is then the insulin, salbutamol, etc. But you don't need to know the doses off the top of your head. You can always check those. Okay. Any questions before we move on to fluids? No? Okay. So NICE recommend the 5 R's of fluid therapy. So these are resuscitation, routine maintenance, replacement, redistribution, and reassessment. The ones that you could be tested on are resuscitation and routine maintenance. They don't ever really test on the other ones because they're quite difficult to make cases on. And the first 2 are the most important, really, as to what you're going to be doing mostly on the wards. So to start off, we have a 46-year-old male who's been seen for acute shortness of breath. On observation, his heart rate is 125, respiratory rate is 23, his temperature is 37.2, blood pressure 90/45, and his cap refill is 4 seconds. So we want you to prescribe a fluid challenge for this patient. So does everyone want to give it a go? Great. Brilliant. Okay. So what are our indications in this case that this patient even needs a fluid challenge? Yeah. Yeah. Okay. Brilliant. So yeah, so the indications are if he's got a low systolic blood pressure of less than 100, heart rate over 90, core peripheries or a cap refill for over 2 seconds, a rest rate of over 20, or he's noosing over 5. And you're all completely right that you give 500 mils of a crystalloid with a sodium concentration of around 130 to 154. Now, I tried not to get too bogged down into the kind of physiology of the fluids that you're going to be using. I had a look at your pharmacy tutorials and it goes into it quite a lot of detail. So if you want to look at the physiology of which fluids are used, then I'd recommend going to there. In the interest of kind of keeping this more as a revision, I'm going to stay away from that. So the crystalloids that you'd use in this case either would be 0.9% sodium chloride or Hartmann's. Now you need to avoid calling it saline. It is commonly called that. However, there are so many different types of saline. So if you just say, oh yeah, you give 500 mils of saline, well, you know, one man's saline is different to another's. So you could potentially be overloading them with potassium, with sodium, sorry. So you don't want to do that. As you rightly said, this is all over 15 minutes. After that, you'd want to reassess the patient, so you check all of his observations again. If they've all gone back to normal, then you're fine. You don't need to give any more. If not, then you can repeat this up to 2 litres. On the second one, so you've given one 500 ml, you give another, that's when you want to escalate to start getting some senior input. It's going to mean that he's quite unwell if he's not responding to a one fluid challenge, so you want to be getting some help. So the way that we write this is on the very back of the chart, there's the intravenous therapy. So with these, you need to make sure that you date them as normal, put the fluid in, make sure that you're really clear on which infusion you're giving. So don't put saline, put 0.9% sodium chloride. You can put NaCl to kind of keep it concise, but it's best to kind of avoid any abbreviations where possible, just to make sure that everyone knows what you're talking about. There's no additive needed in this case, so you just put a line through that. The duration's over 15 minutes. Now, sometimes you might see that this says duration mils per hour. In those that you need to work out what that would be. So for this, it would always be 2000 mils per hour. Proposed start time, we'll say is like now, and make sure that you sign it as well. Okay. So next, you see a 68-year-old male on the ward admitted post-elective cholecystectomy. He has reduced oral intake and decision is made to prescribe maintenance fluids. So he weighs 79 kilograms. Using this little box over here, if you could just work out his daily requirements and then complete the prescription. Okay, has everyone worked it out? Right, so for this man, he'd be needing around 1,975 to 2,370 mils per day of fluids. He'd be needing around 79 millimoles of sodium chloride and potassium, and 50 to 100 grams per day of glucose. So the way that we'd write this up is using 0.18% sodium chloride with 4% dextrose. So does anyone know why we use this rather than 0.9% saline? No? Okay. Yeah? Okay. Yeah. To be fair, that's right. So with 0.9% saline, you're giving 154 millimoles of sodium. So yeah, as you said, that would make them overloaded. We only want to give him 80. So if we give him 2 bags of 0.9%, we're massively overloading him with sodium. So the 0.18% provides 30 millimoles. So if we give him 2 bags of that, we're giving him 60 millimoles of sodium, which isn't quite meeting his daily requirements, but it's almost there, and that will pretty much do for now. It's better to just give them a little bit less and make sure that they're okay rather than ram them full of fluids and just make them overloaded. Again, we need to add potassium because this isn't providing any potassium. Now, the maximum amount that you can give is 40 millimoles per litre. So per bag of fluid you're giving, you can add 40 millimoles of potassium chloride into there. This only comes in 20 ml increments. So you can either give him 40 mils or 20 mils or none. If we gave him 2 lots of 40, we'd be giving him 80 millimoles per day, which is probably a little bit too much. I know he's 79, but it's probably a bit excessive to give him that. So it's better to just start on the lower end and give him 40 and then 20, so giving him 60 millimoles. These will both be over 8 hours, so you're providing him his daily fluids. Again, it's really important that you put the duration and the proposed start time and you sign it. Okay, again, all of this is found in BNF, treatment summaries, and fluids and electrolytes. It's honestly, the BNF is your friend for prescribing. I didn't realise before that you can use the BNF for any question that they ask you in an OSCE. So if they say to you, I don't know, if they ask a particular question that you're not sure of about a drug, you don't need to remember it off the top of your head or come up with something to kind of try and blabber your way out of it. You can just search in the BNF. That is more than okay. It's what it's there for. And they are kind of testing whether you can use it or not. So doing this kind of stuff, and when you're practicing cases, it's really good practice to just try on the BNF and try searching. It's great practice for 5th year as well when you'll be using it for the PSA. Right, so we're going to do a little quiz to finish off. So if everyone just head over to Kahoot, and this is the game pin. Is it not working? Yeah, okay. Try with this pin. So try 561918. Sorry, I'm a bit of a Kahoot novice, I'm afraid. There you go, you're joining now. Sorry about that. Great, okay, let's start. Okay, so first question, which of these opioids is stronger than morphine? Brilliant, yeah, so fentanyl. As we said before, you can just check onto the relative potencies, but it's good to have a basic idea of which is the strongest. Next. So the BNF provides information on opioid prescribing under which section? Brilliant, yeah. So as I said, the BNF is your friend. So all opioid prescribing is under prescribing and palliative care, and there'll be everything you need in that section. So diamorphine can be used in renal impairment, true or false? Brilliant, yeah, so that's false. Diamorphine is not safe to use in renal impairment. The ones that we want to try and use instead are fentanyl, alfentanil, oxycodone. Next. So which of these prescriptions is correct for an immediate release opioid? Brilliant, okay, so yeah, so 5 milligrams of Oromorph, 10 milligrams in 5 ml, PO, QDS. So this is the right answer because it provides the dosing, it provides the right drug, the strength, the route, and the frequency. Zomorph is a modified release, so that's not right. Oxynorm, again, is one that we can use, but this one doesn't provide the strength and is too high. I think that's too high a dose as well. And then the 5 milligrams of Oromorph, we don't provide the strength there, and it's also the wrong frequency. Okay. So which of these is not a sign of opioid toxicity? Brilliant, yeah. So instead, pinpoint pupils are the sign of opioid toxicity, and pretty much the only reason that anyone would ever have pinpoint pupils. So make sure you look out for that. So which of these medications can cause an AKI? Okay, so it's a bit of a trick question, it's all of them. So remembering our Canada mnemonic, then obviously lisinopril is an ACE inhibitor, contrast media, ventromycin is diuretic, and methanoic acid is an NSAID. So true or false, Rivaroxaban requires dose adjustment in renal impairment. Okay, true. Yes. So Rivaroxaban is a NOAC, which does require dose adjustment. So as we said before, if your creatinine clearance is under 30, then the dose needs to be reduced. And if your creatinine clearance is under 15, then it needs to be stopped altogether. So in hyperkalemia, calcium gluconate acts to yeah, smashed it. So it stabilizes the myocardium. Also in hyperkalemia, act rapid then acts to do what? Yeah, brilliant. So it shifts the potassium from the extracellular to the intracellular. So I was a bit mean there and did the thing where they do the opposite. Just make sure you know that it's going into the intracellular compartment. Okay, so in fluid resuscitation, which fluid should be used? Again, a bit of a trick question, so it can be either Hartmann's or 0.9% sodium chloride. This pretty much just depends on your trust, by the way. So it used to always stress me out as to what Hartmann's was and why. It's basically just a fluid that has a lot of different electrolytes in. Some trusts really like it and others don't use it at all. So it's going to just be trust dependent where you work in the end of the day as to which one you'll use. Exam wise, it's best to kind of just keep to one and remember that one. So in fluid maintenance, what is the maximum amount of potassium chloride that can be added to one bag of fluid? Brilliant, yeah, it's 40 millimoles. So you can get it in 20 millimole increments, but 40 is the maximum amount that can be added to 1 litre. Brilliant, so should we see who won? Well done, Jay. Okay. Smashed it. Right, let's turn that off. So, we've gone over today opioids, renal impairment, and fluids. All of the cases, I'd really recommend that you try and do them again in your own time. Don't look at the answers just yet, just give them a go, work on the BNF and work on the prescription chart and see if it makes sense for you, and then you can go through the answers after. On Tuesday, we'll go through anticoagulation and insulin. I hope that this has been helpful. I feel like it's been quite quick, but it's mainly just a whistle-stop tour of everything that you're going to get asked. There really isn't that much, and I'm hoping that this is what this has kind of shown you, that I think prescribing is always really scary, but there's not actually that much that they can ask you in the exam. So has anyone got any other questions at all? Okay, brilliant. So I'm just going to put the link in here for the feedback. If you could all do it, then I'd be much appreciative. Thank you all for listening on a Thursday night. I hope you're all going to go out and do the NHS clap in 10 minutes. And make sure you're all staying safe and looking after yourselves. Bye, guys.